They asked me to talk about therapies, so I will go right to the point since you probably know about things. With therapies it's kind of like taking a sledgehammer to a peanut. I mean, we don't exactly, for most things in medicine, we don't exactly know what we're doing. I've always liked this quote. This was written from the book Candide by Voltaire, written around 1760. Doctors pour drugs of which they know little into patients about whom they know less, with diseases of which they know nothing. Despite that, we have elaborated a number of therapeutic options that seem to work in some people over the course of years for a variety of different kind of autonomic disorders, not just for postural tachycardia syndrome. And one thing I think it's important to realize is there is an overlap between these, that there is an overlap between neurocardiogenic syncope, postural tachycardia syndrome, and the autonomic failure syndromes, much like there's an overlap between emphysema, bronchitis, and asthma. One of the first things that people began to look at, and you have to realize that most of us in this field began looking at neurocardiogenic or vasovagal syncope in the early 1990s, until table testing was developed principally as a diagnostic modality for that, and then along the way we bumped into POTS. So this was a trial sponsored by Dr. Bob Sheldon, who's here. It was sponsored by the University of Calgary, where we looked at beta blockers in treatment of neurocardiogenic syncope. And it's important to realize this was the first of a group of double-blind, randomized, placebo-controlled trials. And interestingly, if you look at the outcomes of treating people with metoprolol, it turned out that there didn't seem to be significance. But you have to always be careful when you're looking at data, because if you looked at the data more carefully, what you found was that in younger patients, it tended to make them worse, and in older patients, it made them better. And 42 just came out as a statistical sort of cutoff point. So from this, we learned that there could be an important age differentiation in who responds to what. Now, this would not be unusual. For example, I am a cardiologist. I deal with both children and adults, and beta blockers are the mainstay of therapy of cardiomyopathies or heart failure in adults. But they don't work in kids. You know, you would think they would work, but the studies have not shown that. We don't know why. So there can be an important differentiation between age groups. Midodrine is a drug that was developed in the early 1990s. It is an alpha-1 receptor stimulant. It's been on the market for a while. It came on the US market approximately in 1995 or 96, and it was originally intended for the treatment of orthostatic hypotension, and it's only one of 2 drugs approved by the US FDA for the treatment of orthostatic hypotension. It is a vasoconstrictor. It stimulates alpha receptors all over the body, which means it also stimulates them in the skin. It gives you a goosebumps-like sensation. It also gives you a sensation of tingling on your scalp, producing a pileoerection. And we actually use that as a therapeutic marker. There are some patients, for example, we only give this drug to as they need it because it works within 15 to 20 minutes. And so some people just take it when they need it. And we tell them when you feel those feelings, that means it's working, and now you can get up and do what you want to do. This has been subjected to a number of studies looking not only at orthostatic hypotension, for which it was approved, but also this was a double-blind, placebo-controlled trial in neurocardiogenic syncope that showed a favorable result. Another double-blind trial was done comparing it just to fluid therapy, or not double-blind, but blinded trial, randomized trial with fluid therapy, and you can see that the outcomes are significantly better. We theorized in neurocardiogenic syncope that there was some kind of central nervous system trigger that seemed to precipitate a withdrawal in sympathetic activity, because in neurocardiogenic syncope, one of the things that's different about them is during their syncopal events, their sympathetic nervous system activity just stops. There is zero there. There is only parasympathetic activity. As a consequence, you have a decline in heart rate and in also blood pressure. Now, based on studies done by Dr. Abboud at the University of Iowa, he theorized that serotonin stimulation was a trigger for these, and that he felt that because of the fact that you had low levels of serotonin, it made you more sensitive. Serotonin, we know a lot about. It is produced in the brainstem and distributed throughout the brain. It has about 45 known functions within the brain. This was from the work of Dahlstrom and Fuchs, who won the Nobel Prize in 1995 for their work in elaborating the production and distribution of serotonin. Whenever you don't have enough of something in the body, you make more receptors for it. It's called Cannon's law of deinnervation hypersensitivity. So if you don't have enough serotonin, you make more serotonin receptors. Then that makes you hypersensitive to small fluctuations in serotonin levels. And so drops or changes that could usually produce a relatively small response could produce a dramatic one. And so we theorized that perhaps you could downregulate serotonin receptor density, and the main drug we had to do that was serotonin reuptake inhibitors, which prevent the breakdown of serotonin, increase the intersynaptic concentrations, and produce a downregulation in receptors. We published a series of early preliminary studies, showed that it would work, again, looking at neurocardiogenic syncope. This study was published in 1999 in the Journal of the American College of Cardiology. It was a double-blind, randomized, placebo-controlled trial of paroxetine in neurocardiogenic syncope. You cannot cross these people over because of the fact that the effects stay in your system for months and months and months after, even if you stop it. So it was impossible to do a crossover type trial. Nonetheless, they looked at patients with recurrent syncope. They were followed for over 2 years, and the recurrence rate in the paroxetine group was 17.6%, whereas the recurrence rate in the placebo group was 52.9%. So it was pretty convincing evidence that there was an effect there. Pyridostigmine has been on the market for a very long time. It was I remember studying about it in medical school when I started medical school in 1976. And there was some brilliant work by Steve Verino when he was at the Mayo Clinic showing that, at least in some patients, they had autoantibodies to postsynaptic acetylcholine receptors in the autonomic ganglia, almost a kind of autonomic form of myasthenia. So the idea came about, perhaps we could treat these people with pyridostigmine. And indeed, the first open-label trial was published by the Mayo Clinic in 2003. That was followed by subsequently by a double-blind, randomized, placebo-controlled trials done by both Mayo Clinic in orthostatic hypotension and by the Vanderbilt group in postural tachycardia syndrome. Both these were double-blind, randomized, placebo-controlled crossover trials that showed a significant benefit in the treatment group. Now, the one problem I had with this, and the one problem you have with all controlled studies, is the fact that you choose these perfect patients. So to give you an example, we see between my partner and I, we see close to 3,000 to 4,000 patients in our autonomic clinic per year. We were part of the droxidopa study to get this drug approved, and they had a series of very rigid criteria that we had to meet for patients to be included in that study. Of that group of patients, we had 3 people that qualified for the study. 3. So and this is for all studies. This is for all studies. That's one of the problems with them. And so you choose this group of people who are these pure as gold patients, but have no relation to reality. And so what happens is, how many times have you heard of drugs coming on the market after having gone through all this approval process and all these studies, only to be yanked off the market in 6 months because they're killing people because they weren't really looking at it in real-world situations? So we decided to do a real-world study, and we looked at 203 really sick puppies who were very ill, who oftentimes, now in these other studies, they were on no other medicines. We did not do that because that's not reality. These people are oftentimes on a bunch of different medicines. And we followed all of them. The longest follow-up time in the 2 studies I mentioned previously was 3 months. So we followed people for a minimum of a year. And what we found is it didn't work as well as was reported previously, but it worked pretty well. It worked in 51% of people. So it reduced fatigue in about 55%, palpitations in 60%, pre-syncopal symptoms in about 60%, and syncope itself in 48%. So it wasn't perfect, but not bad. One of the early drugs we looked at because of other research was erythropoietin. Erythropoietin came on the market in the mid-1980s as a treatment for anemia. It stimulates bone marrow production of red cells. It was brought on the market initially to treat anemia associated with renal failure. Patients on chronic dialysis with renal failure frequently become very, very anemic, require tremendous amounts of transfusion, and indeed, at that era, 25% of the nation's blood supply was being given to dialysis patients. That's how big of a problem this was. And so they began using it to stimulate red cell production in the dialysis population. But they noted something funny. Before the red cell count changed, and it takes about a month for it to really kick in, these patients were becoming extremely hypertensive, like blood pressures of 200 over 120. but before the red cell count had budged. And so everybody said, this must be doing something else that we're not aware of. It has to be having some other action. What turned out is a nitric oxide scavenger, and it produces vasoconstriction. So starting in 1993 in the New England Journal of Medicine was the first paper using erythropoietin as a therapy for severe orthostatic hypotension, where they found it worked in about 70 to 75% of patients. The next year, the group at Vanderbilt published virtually identical results. We published a paper in orthostatic hypotension the same year, and then Dr. Kaufman's group in New York published almost identical findings as well. As far as looking at it in postural tachycardia syndrome, we published this paper. Now, this is an injected drug. It has to be injected weekly. We start people at 5,000 to 10,000 units and injected subcutaneously weekly. You have to monitor the red cell count. When we first started using it, we worked closely with hematology. We said, you know, because what will happen is when you give enough of this stuff, the red cell count will come up almost as a side effect, you know, just the same way that high blood pressure is a side effect in the renal population. So we said to hematology, well, what's a safe hematocrit? What is a safe level? And they said, well, it's really not dangerous to people till it goes above 60, but half the population of Denver has a hematocrit of around 50, you know, because of the high altitude. So 50 should be a safe cutoff. So that's the cutoff we use. And if your hematocrit goes over 50, we hold the dose, cut it back. We do it almost like if you're giving somebody Coumadin. So the starting dose of erythropoietin in cancer is 40 to 60,000 units, starting dose. So the most we've ever given anybody is 20,000, so we use considerably less. We found that it works extremely well, probably one of the most effective drugs we use in treating their symptoms, and it works in 71%. We've never had a single serious problem. On the other hand, the same women who run our Coumadin clinic run the erythropoietin clinic, and they follow these people like hawks. You know, again, the same way you do Coumadin. They are rigid about getting monthly CBCs, you know, staying on top of them. And the problem is it is prohibitively expensive. It costs about $25,000 a year to be on. Another drug that we've used extensively now is in refractory patients has been Octreotide. Now, studies done at the Mayo Clinic and some brilliant studies done by Dr. Julian Stewart from New York, who's here with us today, have shown that a lot of the blood pooling is actually in the mesenteric vasculature that people have. They pull it there. Again, there's not that much room in your legs for that much blood. It's when people go into shock. When people go into septic shock, you may not know this, but the vast majority of blood is in the mesenteric vasculature. And we know this by doing technetium labeling studies, and we can see where it is. So it's no guesswork involved. So the idea arose, and I wish I could take credit for it, but to give credit where credit is due, Dr. Hethke at the University of West Virginia came up with the idea first of giving Octreotide, which is a mesenteric vasoconstrictor. So again, if most of it's in the mesentery, give a drug that can constrict the mesentery. And he showed it would, in a series of 2 papers he published, showed that it would work. This was a paper that we did in people who had failed everything else. Now, it is injected, there's 2 forms of it. There's a short-acting form, which is injected 2 to 3 times a day. The starting dose is 50 to 100 micrograms. You go up to as high as 200 micrograms. It's also somewhat expensive, but it worked in 50, and I apologize that something funky happened to the slide, but it worked in 50% of the patients who had failed every other modality. And in some patients, it's been extremely effective, both in postural tachycardia syndrome and in severe orthostatic hypotension. Interestingly, in POTS itself, one of the interesting indicators is there's a drop in heart rate when you give it. This is a series of patients that we looked at, and the declines in heart rate that would occur because of the increase in vascular resistance and the fact that you're pushing the blood back out into the splanchnic, from the splanchnic into the regular circulation. Interestingly, I was worried that people would become hypertensive on it, but that doesn't seem to be a problem. We have not really seen that in any of this data. Ivabradine is in the United States a new drug. It has been available in Europe and in Israel for 22 years. The delay in it coming to the U.S. was due to a prolonged legal battle over who owned the U.S. distribution rights. Welcome to America. It is a very unique drug. It blocks the slow sodium channel, the IF channel, which governs spontaneous depolarization rates, principally in the sinoatrial node of the heart, but somewhat in the AV node. it will slow down heart rate with no effect on blood pressure. Beta blockers and calcium channel blockers, while they can slow down heart rate, will have an effect on blood pressure of lowering it. And brilliant studies done at Vanderbilt showed, so as your heart beats faster, so you're pulling blood peripherally, your heart beats faster and faster, but that becomes a problem because the heart can only pump the blood that it receives. And if the blood is sitting in the lower half of you, it ain't pumping it. As a matter of fact, as it gets faster, the filling time in between each beat gets less and less and less. So actually, as your heart rate goes up, your cardiac output begins to decline. And studies have done, published in Circulation at Vanderbilt, showed that by giving small doses of propranolol and lowering heart rate, you can make people better. The trouble is, I can tell you from personal experience, beta blockers make you feel like a slug. And at the same time, they would oftentimes lower blood pressure, and so they were precluded in the majority of patients. So the idea was, well, here we have this drug that doesn't do anything to blood pressure, and we could try lowering it. So we published this trial. We looked at a total of 66 patients. We found that it would work in 76% of patients, so about the same as erythropoietin. These were the kind of symptom reductions that we were able to achieve by giving it. And we just we just finished an identical study in children with almost exactly the same results. I think we had a 69% response rate instead of 76. But basically the same exact result in a pediatric population. Now, this is expensive because of the fact that to make up its losses, Amgen is raping the US public and charging like $20 a pill for this, and they don't even make the drug. They buy it from the French and repackage it. However, we have been able to get it from Canada by mail order for our patients for $90 for 3 months worth at a time. So everybody has been able to get it. There hasn't been a problem obtaining it for any of our patients. People came up with the idea of increasing the whole intravascular fluid volume by using intravenous saline. There was a tremendous amount of controversy about this, and rather than yell and scream at each other, we thought, well, why don't we actually do a study and look at it? And what we did is we looked at 72 patients. They were given weekly administrations of intravenous saline. Most of them were done by periphery. We had some people who had ports. 100% of our port patients were cared for by certified infusion centers. We saw that 93% of people would improve with it. So it seems to be extremely effective. In addition, just as a side note that I'm not sure I put in slides for, or maybe I did. Hydration. So what in the neurogenic, what's called neurogenic or partial dysautonomic, the sort of standard POTS people. Our approach is to use hydration, sodium. We use volume expanders such as fludrocortisone. We found that desmopressin can be a useful alternative to fludrocortisone. Doesn't work quite as well, but some people can't tolerate fludrocortisone due to migraines or it increases acne in young people. Vasoconstrictors such as Midodrine, also droxidopa, which is a kind of a norepinephrine precursor. Droxidopa is sold under the trade name Northera. It is the only other drug approved for the treatment of orthostatic hypotension in the United States. You can use that to your advantage. It is ridiculously expensive. It's $20,000 to be on per year. Again, it's been available in the rest of the world since 1989 when it was first made in Japan. People can get it from Japan for cheaper. Just as a cultural thing, the Japanese think that medicines should be liquid. As part of their culture, they think a medicine is a liquid that you take. So if you get it from Japan, it comes as a liquid. Now you can use this, by the way, because usually the insurance companies will say when we want to use something, they'll say it's not FDA approved for that. So when we ask for droxidopa, we say, by the way, this is FDA approved for it, and then they scream and yell and holler and drag their feet, but eventually we'll approve it. There is a hyperadrenergic form of POTS. These people are characterized by hypertension and also by very high heart rates and high serum norepinephrine levels. Here you have to bring the pressures down. We found that if you give a pure beta blocker, you can make them worse. It's like treating a pheochromocytoma. You're going to block beta sites and activate alpha sites. So we use drugs like labetalol is one of our favorite drugs, Bystolic, which is mevedolol, carvedilol, clonidine, methyldopa, and oftentimes things like biofeedback. In biofeedback, you try to teach people not to respond to things as well, and it seems to work reasonably well. some of our more recent research, many of our POTS patients would complain of episodes of syncope, and we identified 3 factors in our neurocardiogenic syncope population that seemed to predict they were having asystole, which is loss of consciousness with no prodrome, prolonged loss of consciousness greater than 5 minutes out, and also convulsive activity. And we began to hear patients, POTS patients, tell us they were having syncopal events associated with this. And indeed, this is from a tilt done on a POTS patient who went into asystole. So we asked the question, well, maybe there are people out there who are getting really bradycardic or asystolic. And we now have these devices we can implant very easily in people. This was the implantable loop recorder. This is an implantable loop recorder. The one on the large one, we were one of the first centers in the United States to implant this. This was developed in Canada. The smaller one is the newer one. These are injected under the skin in about a 10-minute procedure. They're very easy to put in. You make a small incision, inject the device in, and it sits approximately here. Now, again, people said, well, their POTS patients are just passing out because they're hypotensive and things like that. Well, you can say anything you want as long as nobody looks. Just, again, look at our president. So I'll show you the recording of a POTS patient who was having recurrent episodes of syncope associated with convulsive activity. So this is, and forgive my primitive attempts at blurring her name out, but this shows you her going along just before an episode, and then suddenly you see this. And then you see that. So we've helped pioneer a new type of technology that can actually measure, it's a pacemaker that can actually indirectly measure blood pressure. And it does so by creating a continuous impedance field between the tip of the can and between the can and the tip of the pacer. And when the ventricle is full of blood, the impedance to current flow is less than when it's empty. And so this can track blood pressure. Every beat it gives it. And for the first 12 hours when you put it in, it measures every beat you have and sums them together into a template that's used. We published the first trial using these in refractory syncope patients. This trial, there's been about approximately 10 trials published. All of them have shown a positive response. This was a double-blind, randomized, placebo-controlled crossover trial using this technology in patients with recurrent syncope. It's a circuit you can turn off. So everybody got the same pacer. Half of them had it turned on. They were followed for a year. Then they had the ones that were on were turned off, and the ones that were turned off were turned on. And nobody knew who had what. So the syncopal frequency of those people where the sensor system, pressure sensor system was activated is called closed loop stimulation. Those are listed in the blue line on the bottom, and the other ones are when it's off. So this was, again, double-blind, randomized, placebo-controlled, prospective trial, showed that there was a 7-fold reduction in syncopal frequency with this on compared to normal pacing. We've already shown that normal pacing works. So the paper we just published, we identified 39 patients with POTS who were having recurrent episodes of syncope associated, again, with seizure activity, with abrupt loss of consciousness. All of them underwent loop recorder placement. All of them were found to have periods of asystole. The woman I showed you was one of these patients. All of them ended up undergoing pacemaker implantation, and their response rate is the same as anybody else's with it. So I don't think this is a lot of the patients, by the way. I only think it's around 15% or so, maybe, but it may be more. So when people give us histories that are suggestive, we put a loop recorder in and just ask the question, what is going on out there? And a lot of times we don't see anything, but sometimes we do. Now, as I said, these are things that overlap, and don't get too hung up on classifications. These were not handed to Moses at Sinai. Also, keep in mind, if you've not had the opportunity yet to be sick, I'm a cancer survivor. I lost my first wife to cancer, and illness can wreck your head. And until you've been through severe illness with yourself or with a loved one, you can't begin to understand the emotional distress. And in some ways, looking back at my battle with cancer, I'd almost rather go through everything else than the depression and the emotional part of it again, because that was perhaps the worst part of the whole thing. So keep that in mind. We try very hard to get people into counseling, not because I think something's wrong with them, but rather it's hard to live with a chronic illness. It's hard to have your whole life turned upside down. There's an old Yiddish expression which is man plans and God laughs. So thank you for the opportunity to present this. Again, when we're done, I'll be happy to answer any questions. I didn't quite, given the time constraints, I couldn't elaborate on a lot of things the way I would like to. We probably could spend a whole day symposium on this, but thank you.